Welcome, students, to today's lecture on invasive mechanical ventilation. In this comprehensive script, we will delve into the intricacies of this critical aspect of pulmonology. Invasive mechanical ventilation is a life-saving intervention, used in patients with severe respiratory failure or when non-invasive methods are ineffective. Let us now proceed to explore the indications and contraindications for its use. Invasive mechanical ventilation is used when a patient cannot maintain adequate oxygen levels or breathing on their own. It is used in conditions like severe pneumonia, ARDS, exacerbation of COPD, and during major surgeries. However, patients with severe hemodynamic instability, cardiac arrest, poor prognosis, or terminal illness may not benefit from invasive ventilation. In the next section, we will discuss ventilator modes and settings. Invasive mechanical ventilation is a critical aspect of patient care. It involves selecting the right ventilator mode and adjusting settings to optimize oxygenation and ventilation. Lung protective strategies will be discussed in the next topic. Lung protective ventilation strategies aim to minimize ventilator-induced lung injury, VILI, and improve patient outcomes. These strategies involve the use of low tidal volumes and limited plateau pressures. Low tidal volumes help prevent overdistension and stretching of the alveoli, reducing the risk of barotrauma. Furthermore, the application of positive end expiratory pressure, PEP, improves oxygenation and prevents alveolar collapse. The goal is to maintain adequate lung recruitment while avoiding excessive alveolar pressure. We will now transition to our next topic, ventilator-associated lung injury, its pathophysiology, and prevention strategies. Invasive mechanical ventilation can lead to ventilator-associated lung injury, VALI, due to factors like high pressures and tidal volumes. Preventive measures involve lung protective ventilation strategies, sedation management, and early mobilization. Next, we will discuss diaphragmatic dysfunction. Diaphragmatic dysfunction can occur as a consequence of invasive mechanical ventilation. Prolonged diaphragmatic inactivity leads to muscle atrophy and weakness, known as ventilator-induced diaphragmatic dysfunction, VIDD. To prevent and manage VID, strategies such as spontaneous breathing trials, diaphragmatic strengthening exercises, and early mobilization are crucial. Additionally, techniques like neuromuscular electrical stimulation may be utilized to maintain diaphragmatic function. We will now proceed to explore the impact of volatile anesthetics on mechanical ventilation. Volatile anesthetics can significantly impact the mechanics of mechanical ventilation. They provide anesthesia and muscle relaxation during surgery, affecting ventilatory parameters. Volatile anesthetics decrease respiratory drive, necessitating appropriate ventilator adjustments. They also have dose-dependent effects on respiratory system compliance and airway resistance, which must be considered to maintain optimal ventilation during surgery or postoperatively. Now let us shift our focus to ventilator-associated pneumonia, VAP, its risk factors, and management strategies. Ventilator-associated pneumonia poses a significant challenge in the management of mechanically ventilated patients. The risk factors include prolonged intubation, immunosuppression, and colonization of the oropharynx or gastrointestinal tract with pathogenic microorganisms. Preventive measures such as maintaining adequate oral hygiene, elevating the head of the bed, and implementing strategies to reduce the duration of mechanical ventilation are essential. Early identification and prompt initiation of appropriate antibiotic therapy are crucial in managing VAP. Let us now explore the role of extracorporeal membrane oxygenation, ECMO, in invasive mechanical ventilation. In cases of severe respiratory or cardiac failure, where conventional ventilation fails, extracorporeal membrane oxygenation, ECMO, provides a life-saving alternative. ECMO involves the temporary extracorporeal support of oxygenation and carbon dioxide removal. ECMO is used in specific situations such as refractory hypoxemia, hypercapnic respiratory failure, and acute respiratory distress syndrome, ARDS. Implementation of ECMO requires specialized centers with experienced multidisciplinary teams. Now, let us turn our attention to acid-base disorders in ventilated patients, their interpretation and management. Mechanically ventilated patients are prone to develop acid-base disorders, which can significantly impact patient outcomes. Understanding the interpretation and management of these disorders is crucial for optimizing ventilatory support. Common acid-base disorders encountered include respiratory acidosis, respiratory alkalosis, and metabolic acidosis. Ventilator adjustments and appropriate correction of underlying abnormalities are essential in restoring acid-base balance. We will now proceed to discuss weaning and extubation principles in invasive mechanical ventilation. Weaning from invasive mechanical ventilation aims to liberate patients from ventilatory support and successfully transition to spontaneous breathing. This process involves a systematic and gradual reduction of ventilatory support. Key principles include performing spontaneous breathing trials, assessing for readiness to wean, and monitoring for promising weaning parameters such as respiratory rate, tidal volume, and respiratory muscle strength. Adequate patient assessment, clear communication, and identification of potential complications are vital in successful weaning. Let us now shift our focus to non-invasive ventilation as a bridge to extubation. Invasive mechanical ventilation carries risks such as barotrauma and adverse effects. Timely recognition and management of complications are key. Invasive mechanical ventilation can lead to various complications that must be recognized and managed promptly. Barotrauma, such as pneumothorax or pneumomediastinum, can occur due to high pressures generated during ventilation. Additional adverse effects include ventilator-associated lung injury, ventilator-associated events, and ventilator-induced diaphragmatic dysfunction. Strategies to prevent and mitigate these complications include lung protective ventilation, meticulous care of the ventilator circuit, and implementing sedation protocols to minimize complications associated with patient immobility. Now, let us summarize what we have learned in this comprehensive script. Invasive mechanical ventilation is crucial for severe respiratory failure. Understand indications and contraindications for proper utilization. Learn about ventilator modes, lung protective strategies, and complications. Your knowledge will improve patient outcomes. Keep exploring this fascinating field. Best wishes for your medical careers.